Today we are going to talk about management of poisoning. So, toxicology is the science of poisons. Matthew Orfila is considered the modern father of toxicology. You would see a lot of poisoning cases in an emergency once you start coming to the ER. There are various types of toxicology: ecotoxicology, environment toxicology, medical and aquatic toxicology, as well as entomotoxicology. You might have studied this in forensic, but again, poison can be any substance which can be delivered to any route, which can cause ill health or death. Anything can be a poison if given in abnormal doses. Okay, anything which has effect will have a side effect. So, a toxic substance is simply a material with toxic property, which is different from a toxic agent. That is anything that can produce an adverse biological effect. So classification of poisons, this is very important according to local action because the management changes. Corrosives and irritants. So corrosive, strong acid, alkali and metallic salt. Here you don't do lavage because it will, if the patient has ingested it and you do a hard lavage, then patient's esophagus might get damaged or stomach might get damaged, and there is irritant, agricultural, inorganic, organic. Then in the local action, once again. Uh, so again, there apart from the corrosive and irritant, there can be other classification. Those which act according to site of action for cerebral, spinal, and peripheral nerves. For example, opium, alcohol, antidepressant, datura. This will have cerebral effect. Spinal, stricus nux vomica, strychnine, and peripheral nerves like cocaine and procaine, and muscle relaxants. Then other thing according to motive or nature of use: homicidal, arsenic, digitalis, strychnine; suicidal, opium, barbiturate, organophosphate; and accidental, aspirin, organophosphate, snake bite, carbon monoxide, H2S; abortifacient, ergot, stupefying, datura, cannabis. This has importance in mm, taking history, etc. That is, these are the common poisons which are associated with it. Okay. So coming to management of poisoning. Again, the management of poisoning consists of these steps: resuscitation and initial stabilization. This is very important. Diagnosis of type poison. You always have to take gastric lavage as per law. Mm, Non-specific therapy, specific therapy, and supportive care. These are the basics. Resuscitation. If possible, you diagnose type poisoning. Otherwise, you try unknown poisoning. Non-specific therapy, there are some standard steps. Specific therapy as an antidote. It is not unsupportive care. Okay, so resuscitation and initial stabilization. Again, airway, breathing, circulation. If there is trauma, then stabilize the C-spine. Drugs, if possible, will give antidotes, or you can give gastric if patient is vomiting. You can give PPI or antiemetic. You do ACLS if it is necessary. What are universal antidotes? Drugs like broad spectrum drugs like charcoal. You can give a charcoal at 1 gram per kg, so it's a broad spectrum decontaminant. You can give water saline for lavage so that it can dilute it. You can draw blood, you do a standard test. Decontaminate, that is, if the patient has skin exposure, you tell him to remove his clothes, etc. Expose, look for specific toxidromes, right? For example, acid, anticholinergic side effects. Okay, organophosphate poisoning, which has cholinergic side effect. So you will have sweating from blood, sweating from axilla. So you have to expose and examine the patient also. Pupils are very important. To example that to study the toxidromes, which I'll be talking later. Then you will do a full vital ECG, Foley X-ray, and you will see and give specific antidotes. Diagnosis of type of poison depends upon history examination. History is very important. many times patient will be not conscious, so you will have to take it from their relatives. Examination has to be head to toe because it's a medical legal case. You have to be very careful in history and examination, document everything. So examination, you have to look for sign of trauma. Very important. Many times patient will not give correct history for the fear of retribution of the fear of case. You have to take it appropriately. Signs of seizures, signs of infections, chronic alcohol abuse, drug abuse, mental status, and specific toxidromes, that is opioid poisoning, anticholinergic, sympathomimetic. So, as toxidromes helps in broad classification. Right, a toxidrome is a constellation of findings either from physical examination or from ancillary testing. Okay, so why is it important? Because it roughly characterizes what is the most common type of poison. For example, you would see a lot of poisoning by taking overdose of alcohol, narcotics, sedative, hypnotic. So here what will happen? Hypothermia, bradycardia, hypotension, your pupils will be constricted, right, in opioids, and slow respiratory rate. So the moment we see it, we can see that patient has a sedative, hypnotic, or alcohol overdose. So it is different type of drug. For example, naloxone or flumazenil, or for alcohol, alcohol overdose also. Okay. Then sympathomimetics drugs, ephedrine, etc. You can cause increased temperature, CNS excitation, tachycardia, nausea, vomiting, hypertension, direct pupils, ephedrine, cocaine. So these can cause these type of side effects. So again, pupils are the key and the vitals. You see. Then drug withdrawal. For example, if the patient is alcoholic and now has stopped alcohol, you will see a lot of tremors, increased temperature, agitation, tachycardia, hallucination, seizures. So you will have withdrawal. Tremor are patient will be restless. Seizures are very common on day 4 of alcohol withdrawal. Cholinergic, very common thing in organophosphate poisoning. So, cholesterol. So, Dubbells is the mnemonic. Diaphoresis, urination, meiosis, that the pupils are constricted, bronchoria, lots of secretions, emesis, lacrimation, salivation, lots of secretions. Anticholinergic, typically in antidepressants have anticholinergic effect. Hyperthermia, dilated pupils, decreased sweating, vasodilatation, datura has anticholinergic action. Tachycardia, hypertension, urinary retention, especially in elderly. So extrapyramidal. So extrapyramidal side effect can be there. Okay. Due to antidopaminergic, very commonly seen if you are seeing metoclopramide or any old antidepressants like haloperidol, dysphonia, rigidity, tremors, torticollis, laryngospasm, trismus, and oculogyricrisis. That is rolling of eyelids. So these are roughly the toxidrome findings. You can have a look at stop this video show and look at the things, right? And this is very important. So basically, you have to examine pupil, CNS, the consciousness, cardiovascular, skin. You have to see, and bowel signs you have to see. So what is the use of clinical labs in initial diagnosis of poisoning? A lot. You have to take APG. You have to see hypoia, hyperventilation, electrolytes. You have to see metabolic acidosis with there is an ion gap or non-anion gap. ECG, sometimes wide QRS in tricyclic antidepressants. Then X-ray, this can be helped sometimes in looking if the patient has taken radiopaque pills. And if you are suspecting specific things, for example, paracetamol, you have to do a paracetamol level because that would decide about the level of treatment we have to give. So, what is the non-specific therapy? Gastric decontamination. How do you do it? You do an MSS, though not recommended routinely nowadays. You do a gastric lavage either with plain water or KMNO4, and use of activated charcoal. Again, cathartic is not very common, so you have to do whole ball irrigation. You can do a forced alkaline diuresis, and if nothing works, for small molecules, which can do dialysis, peritoneal, and hemodialysis. So we'll look at the specific therapy, acetaminophen. Very antidotes are very less common in some of them. For example, commonly used paracetamol and acetylcysteine, commonly used anticholinergic, neostigmine, fuostigmine, commonly used. Arsenic, you do a chelation, beta blocker, glucagon, benzodiazepine, flumazenil, carbon monoxide, oxygen, ethylene glycol, methanol, you use ethanol. So these are opioid, naloxone, organophosphate, atropine. They are very commonly used. So these are the common doses. You can stop the slide and see. Uh, in particular, you would see a lot of atropine, cholinesterase, organophosphate poisoning. You would see this a lot in your practice. Atropine proredoxin, very commonly used. Antivenom, very commonly used. Okay. Naloxone, sometimes you commonly seen. The rest probably you will see in ethanol is also seen, but these are less commonly seen, but they might be seen. So you have to keep your eyes open. Supportive care post cases of poisoning is largely supportive. Don't waste time locating an antidote and do supportive care. You look for coma, seizure, hypotension, arrhythmia, manage it in an ICU. So again, these are the ANS you already might be knowing, which are excitatory inhibitory both. So I will not dwell upon them, and they can have cardiac effect as well. Again, I'm not going to deal on that. So this is a common type of poisoning that is I was talking about. In an Indian study, it was seen that 57% patient had consumed insecticide, 29% had unknown, alcohol, rat poison. So organophosphate is very common. Unknown poisoning is other common. Alcohol, very common. Rat poisoning, other common. Then corrosive poisoning, phenol, etc. other common. These are actually the most, and mosquito repellent in some patients. So these are common type of poisoning. So you must know their management. So pesticide poisoning, this is very common poisoning. You would see one of the most common poisoning inside our scenario. So pesticide, mainly these are various forms. You would see the insecticides very commonly, in particular anti-organophosphates, right? Sometimes it can have ivermectin, etc. Erythroid toxicity is also common. And your insecticide, sometimes your rodenticide, zinc phosphate, aluminum phosphate is common. So this and this is very common. So they are the trade names. Uh, again, then pyrethrum, very common in mosquito repellents, etc. Then the label color is very important. You can read and you can stop and see the slide, but I'm not going to go in detail about that. And you have, because according to label there is characterization. Government of India has banned many of these molecules now, I think, for common use unless they are approved. So, for example, zinc phosphate is a very dangerous poison. Right. Okay. Organophosphate poisoning very commonly found in our setup. You would see there. So, how do they act? Obviously, they would irreversibly bind and deactivate the cholinesterases. So, acetylcholine will, accumulate in neural synapse, causing CNS and PNS overdrive. And mortality will happen due to cholinergic. So, it's a cholinergic tox syndrome. But again, in baby, it is symptoms difficult to consider. You will have meiosis, but you will still have meiosis and salivation, and you will see increased serum acetyl. If you are unsure, you can always observe serum acetylcholinesterase level. So again, the classical representation: dumbbells, diarrhea, urination, meiosis, bradycardia, emesis, lacrimation, salivation, and this is a very common. Or the odor, garlic-like odor, is very common. CNS, again, nicotinic side effects first, because So you will have increased acetylcholine leading to nicotinic. So you will have muscle fasciculation and then flaccid paralysis. So muscle fasciculation is due to ganglionic stimulation. Thereafter, you will have flaccid paralysis, visual, pinpoint, non-reactive pupil, respiratory, cardiovascular, and GI side effects. So workup, obtain the original container, look for parasympathetic and CNS signs. Diagnostic test, as I told, that plasma cholinesterase level you can do, though RBC true cholinesterase level is better. So these are markers. When you do markers, when you're not able to locate the the clinical diagnosis is less certain. So apart from it, you do a CBC, electrolyte, arterial blood gas, ECG. But when you're very unsure that what is causing the artery, you can also get a CT scan. So treatment, obviously, you decontaminate, lavage, charcoal, remove all clothes and store as toxic waste. Very important. You have to store the lavage because for medical legal evidence. You have to decontaminate skin with soap and water if it has been infected. Initially stabilize, you treat hypotension, ABC management. For unstable airway, intubate, ventilate, and you start giving fluids. If there is an altered mental state, you can also consider glucose with thiamine. So once we establish atropine, we initially start uh, uh, atropine at 2 mg. That is, patient will come with meiosis, lots of salivation, typical garlic odor. We start 2 ampules of atropine, and we can double the dose every 5 minutes till your pupil dilation or your secretions will stop. Okay, and we can in early first 24 to 48 hours you can give pralidoxine 1 to 2. Okay, every 6 hourly. So this is very important, very common treatment you will see in our emergency medicine. Then ICU admission for any exposure confirmed with atropine response. So how do we know it? Once you give atropine, you will see some amount of response. So that is also a therapeutic diagnosis, right, of organophosphate poisoning. So you will generally admit these in ICU. Okay. Then discharge criteria asymptomatic for 6 to 12 hours after exposure. And obviously you have to get a psychiatry evaluation first, because what was the motive? It was suicidal or it was accidental. And other thing very common is aluminum phosphate poisoning. This is very dangerous cell loss in India and Iran, and it is lethal dose is 1 to 1.5 mg, but very low doses can also cause death. So why is it causes the death? Because it liberates a lot of phosphine gas, and here the patient will initially look all right, but the phosphine gas will keep on uh, getting secreted inside the body. It will react, do chemical reaction, and patient will gradually deteriorate. And since there is no antidote, you will not able to do much, and it will have tremendous cardiac and vascular toxicity. And you see frequency of hypertension is 76% to 100%. So you will see a lot of blood pressure fall, and that is why you should always get an ECG done. Arrhythmia, respiratory failure, and mechanical ventilation. Metabolic acidosis is pretty common. So once you have aluminum phosphate, you suspect aluminum phosphate poisoning, you do a gut contamination. Again with lavage, you put a Ryle's tube. If the patient is unconscious, with K-menophos, you do give activated charcoal. Here, coconut oil is also used. So this is very important. And then when magnesium mostly supported, you give antiarrhythmic if there is arrhythmia or heart block, and plus magnesium sulfate. Other things for metabolic acidosis, you can give sodium bicarbonate, etc. So very important. Zinc phosphide, again, it's a rodenticide available as a pellet. Again, it also produces phosphine gas, and here the death is fast. Okay, zinc phosphide, a faster thing. And here only 500 mg is often fatal. The management on basically similar lines, except here you will have to repeat INR because it's a rodenticide, so you will have liver effects as well. You will do INR. And if coagulopathy is seen, vitamin K or FFP is given. If there is INR increase, then hematemesis or hemopsis, etc. is seen. Then coming to pyrethroid. So pyrethroid, these are natural pyrethrins commonly used in anti-insecticide, anti-mosquito drugs. Pyrethroids have relatively low toxicity, but again, these are ion channel toxins. You can have voltage sodium, neuronal voltage act on neuronal voltage sensitive sodium channels, and they can prolong sodium excitation. So you will have paresthesia, nausea, headache, vomiting, like first source, and then followed by CNS depression and severe as seizure and coma. You will commonly see in this all out, etc., or you have mosquito uh, repellents, etc. No antidotes. You rinse the water. Thermal exposure after accidental. If some people ingest it, you can give activated charcoal, and hypersalivation can be treated with atropine. Now, this is another very common poisoning, corrosive. Here, you have capacity to cause tissue injury on contact and by chemical reaction. So, since you are ingesting it, you can, for example, phenol, etc., other corrosive Cl. So most commonly affect GI tract. So here the estimated prevalence is only 2.5 to 5%, but morbidity is 50% and mortality is 13%. What will be the morbidity if the patient has ingested? So you'll have corrosive action, which will have either coagulate, cause coagulative, or some form of necrosis, and it will cause strictures or mediastinitis. So you have acids and carbitary fluid, metal cleaner, alkalis. These are commonly homicidal poisoning because it is very painful. Common caustic is HCl used as toilet cleaner, sulfuric acid in automobile batteries, sodium hydroxide in paint remover, phenol as an antiseptic. So factors determining corrosion, obviously it will be form, solid or liquid, duration of contact, concentration, pH, and food presence or absence. So alkali injection will cause liquefaction necrosis, and acid injection will cause coagulation necrosis. But however, both will cause fibrosis and scar formation. So necrosis will occur within seconds of exposure to caustic, ulcer and perforation within 24 to 72 hours, fibrosis within 14 to 21 days, and stricture weeks to years. Carcinoma formation after decades. So GIT, you will have corrosive poisoning if the patient takes acids or alkali. You will have severe pain of lips on excessive salivation, dysphagia or dyno. Patient will be in a lot of pain. Symptom and sign of GI perforation like lot of chest pain, abdominal pain, hard and rigid abdomen. Respiratory symptom again cough, dyspnea, eyes and skin will pain and burn at site of exposure. Investigation, CBC, electrolytes, and the general standard tests. X-ray, mediastinal. If you are suspecting a lot of dyspnea, you can get an X-ray and see for pneumomediastinum, because esophagus will get perforated and you will see pneumomediastinum. Abdominal X-ray, again pneumoperitoneum. You can see CT to assess esophageal wall thickness to predict response of dilatation. So here, very important, endoscopy. If patient presents early, you have to get endoscopy done in 48 hours to look for, especially in which patient. If it is done in small children, if the older children are adult with a lot of symptoms, typical, you have dysphagia, odynophagia, dyspnea, altered mental status, and if the patient has taken very large volume and concentrated volume, these are the upper GI. Why? Because you do a survey to look at the level of damage inside. Okay, but again, in these conditions only, if the patient has taken large volumes, very concentration, if patient is having typical symptoms, and you have to do it very early. After 2 days, it will not have any effect, because what has happened has happened. So, okay, and when don't you do it? When you don't do it, so in hemodynamic compromise, the patient BP falls, you don't do it. If the patient has peritonitis and mid-stat, you don't do it. And if the patient has mild invasion, very small amount, then you don't do it. Otherwise, if it is moderate to severe, you do it. So it is a moderate range. You have to do upper GI endoscopy. There is Jargar's classification. It is helpful in the management. What is the prognosis? Alright. If it is only minor, then you don't need. So within 48 to 72 hours, upper GI endoscopy performed in day 1 to 2 in corrosive poison. If endoscopy only mild lesion, then you can discharge. If severe lesions are found, then you can do a surgical gastrostomy because patient is going to have strictures and you have to feed it somehow. So you will put a surgical gastrostomy. If the patient comes to you late within 72 hours or 3 weeks, you don't do endoscopy. And if there's severe dysphagia, you will do a gastrostomy and let the stricture develop. And after 3 weeks, you can do an endoscopy and dilatation of stricture. If it is after the patient comes after 3 weeks, then most probably dysphagia will appear, stricture will appear, and you do endoscopy and dilatation of stricture. If successful, then you do monthly endoscopy. If it is unsuccessful, you do a surgical gastrostomy. So clinical approach, if you have asymptomatic corrosive, then no oropharyngeal burn, then only observation in emergency room. If it is symptomatic, if there is ingestion of large volume, signs like stridor, hoarseness, respiratory distress, you will admit in ICU. If patient is presented early, you get an early endoscopy. You do a protection of airway. And if it is supraglottic edema, etc., lots of stridor, then you might have to do intubation. Hemodynamic status done by replacement with IV fluids, crystalloids. Gastric emptying, as I told you, is contraindicated. Don't do lavage in these guys. In corrosive poisoning, steroid, no role of steroids, and you can give PPIs. Stricture management, as I told, it has to be done after 3 to 6 weeks, and if it is not successful, you have to do surgical gastrostomy. Thank you. Hope it helped.